So good evening, everyone, and I would like to thank Shyam sir for giving me this opportunity to present this topic. So I'll be discussing on role of immune checkpoint inhibitors and chemo in neoadjuvant TNBC. So we know that triple negative breast cancers contribute to 30% of all invasive cancers, and this is the Association of Surgeons 2020 data. And the incidence of triple negative breast cancer was higher in patients who are younger, premenopausal, as compared to the age group of 35 to 70 years. And globally also TNBC accounts for 10 to 20% of all breast cancers. Majority of TNBC we know are basal-like or claudin low. So they have a genetic heterogeneity and their patterns of gene expression are heterogeneous. Given the lack of effective treatments in this type of breast cancer, so there are several trials, several efforts have been made in recent years to increase the therapeutic approaches for TNBC patients. So if we see the survival data, so the rates drastically drop for TNBCs if stage by stage comparison is made. And if caught early, a patient has approximately 60% chance of surviving 5 years. So earlier, the diagnosis is very important. Patients with triple negative subtype, they are younger, they are premenopausal in majority of the groups, and the higher proportion of TNBC, they present in locally advanced stage, and they have a high proportion of more positive patients as compared to the non-TNBC counterparts. So I think it may not be clearly visible. So this was the profile of triple negative patients in India, and they clearly showed that most of the patients presented in LABC and they were younger and premenopausal subgroups. So now if we talk about the role of NACT in breast cancer basically. So the dictum holds on to downstage the tumor actually. So we use NACT in breast cancer. However, there are certain high-risk subsets like TNBCs and HER2 positive, where we literally somewhat expand this criteria. And chemotherapy, as we know in TNBC, for that matter, neoadjuvant or adjuvant is recommended in women with TNBCs more than 0.5 centimeter or with node positive, regardless of the tumor size. Because these patients have higher risk of relapse as compared with other breast cancer subtypes, and they are not candidates for other form of targeted therapy as well. So for these patients receiving NACT, PCR is associated with the actually improvement in DFS. And like we were discussing in previous panel discussion also, in these high-risk subsets, DFS is actually seen as a surrogate markers for improvement in survival. Though absolute advantage in overall survival is yet to be seen in these subgroups who receive NACT with or without any targeted or IO agents, but DFS is an important marker which has been seen associated with whether we incorporate neoadjuvant carboplatin in these subgroups or neoadjuvant immunotherapy. And additionally, one important factor in TNBC is, so early TNBC may often be neoadjuvant chemotherapy, particularly if we think that there might be candidates where additional treatments like adjuvant capecitabine and other things would make a difference in actually overall survival. So till date, anthracycline or alkylating agents, taxane-based chemotherapy regimens, they remain the standard of care regimens in NACT and TNBC. However, some non-anthracycline-based regimens are an appropriate alternative for patients with lower risk TNBC like node negative, less than 1 centimeter, or where we tend to intentionally avoid anthracyclines like cardiac risk factors, and those who prefer to avoid risks associated with anthracyclines. So where does the role of carboplatin stands in neoadjuvant setting in TNBC? So there are basically 3 large randomized trials and and some phase 2 trials also which address this issue, and they have certainly shown that PCR rates are better, are improved when we add carboplatin to the neoadjuvant chemotherapy armamentarium in TNBCs. To mention or highlight a couple of them, so this was GPAR-62 trial which actually saw the survival analysis of carboplatin added to an anthracycline taxane-based NACT, and they also finally saw that subset if HRD score was a predictor of response in these subgroups. So what they did was they gave paclitaxel plus non-pegylated liposomal doxorubicin and add on carboplatin as the experimental arm. The secondary study endpoint included DFS and OS, apart from the primary endpoint of PCR also. And they also tried to look into whether HRD or homologous recombinant deficiency was defined, I mean, whether it made a difference in the carboplatin receiving group or non-receiving group. And they defined HRD as HRD score of 42 as a positive, 42 or more as a positive versus less than 42 as a negative HRD scoring. And they saw that there was significantly better DFS with a better hazard ratio of 0.56 in patients with TNBC who received carboplatin as the neoadjuvant arm. HR deficiency was detected in approximately 71% of the patients of TNBC, and out of which 60% showed a high HRD scoring, where tumor-mutated BRCA was not seen actually. And adding carboplatin to the arm actually made a difference in increase in PCR rate from say 34% to 65%, especially the HR deficient. However, it was seen that adding carboplatin actually made a difference in non-HRD high score patients also. So DFS rates were improved with addition of carboplatin in both of the groups. The quantum of benefit was more in HRD deficient patients rather than non-HRD. So this study concluded that addition of carboplatin to neoadjuvant arm improved DFS, which was significantly better in TNBC. Long-term survival analysis, though, support the neoadjuvant use of carboplatin. However, we have yet to decide DFS as a surrogate marker for that end. HR deficiency in TNBC and HRD score in non-tumor mutated BRCA are predictors of response. However, the response does not depend upon the HRD scoring actually. So now another study, though this study which was GPAR Octo trial, the primary endpoint was not exactly to see the quantum of benefit with carboplatin. The primary intent was to see whether the dose intensity or dose density could help this TNBC subset to improve the DFS or the PCR rates. And they used dose dense epirubicin, paclitaxel and cyclophosphamide versus weekly regimen of pacli and lipodox add-on carboplatin in TNBC cohort. So they included, this trial actually saw the addition of the chemotherapy arms in basically high-risk group, be it HER2 positive or the TNBC. And HER2 positive patients additionally received the anti-HER2 regimen also. So as you can see in TNBC cohort, basically the HER2 negative and hormone negative. So the dose intensity and density does not matter actually to achieve that PCR. However, numerically, the patients who received carboplatin had a better PCR rate in this trial also. So this also concluded that in high-risk early breast cancer, the dose intensity does not matter actually. And dose intensity is one of the effective and feasibly given regimen in these patients. So if I summarize carboplatin in NACT, so there are 3 randomized trials which showed that improved PCR rates with the addition of carboplatin to taxane and anthracycline NACT, while none of these studies were designed for definitive determination of impact of carboplatin on long-term outcomes. So 2 have reported improvements in event-free survival or DFS with addition of platinum. There are no randomized trials which have directly compared 3-weekly versus the weekly carboplatin. So still unanswerable question whether we should use platinum weekly or a 3-weekly regimen. So in clinical trials, while both germline BRCA mutated or BRCA wild type, TNBCs were more likely to achieve a PCR with addition of carboplatin in NACT. However, the BRCA-ness or the BRCA mutation, the quantum of benefit is much larger. The magnitude of improvement in EFS with addition of carboplatin actually did not differ between both of the subgroups. But however, small number of these BRCA mutation carriers and the limitation in study designs, I mean, they do not give us confidence to conclude in this armamentarium. Now coming to role of immune checkpoint inhibitor in TNBCs. So there are various trials which have tried to look into this question, and to mention or highlight them is Keynote 522, which included pembrolizumab, and IMPassion 031, which saw the effect of Atizo, and GPAR Nuvo, which saw actually addition of durvalumab did make a difference or not. So if we see the rationale, we know there are increased predictors of response to IO and TNBC, basically the tumor infiltrating lymphocytes, the higher expression of PD-L1 and higher tumor mutational burden in these subgroups. Now, this is very important to understand that the companion diagnostic test with each of the immune checkpoint inhibitors is different. So, the results are expressed in terms of CPS in pembrolizumab or IC scoring in atizo. So, we need to understand that the simultaneous companion diagnostic test should be used when we are deciding for one or the other immune checkpoint inhibitors. So this trial was actually I-SPY 2, which tried to assess whether the addition of novel therapies like immune checkpoint inhibitors did make a difference in different cohorts with the addition of these targeted agents along with chemo in the NACT arm. So this trial concluded that the patients who, this trial gave actually two good messages, that the patients who actually achieved the PCR, they had a good EFS, irrespective of whatever the regimen was used in the NACT arm, and the patients who used, who did receive IO along with chemo, they did even better, even if they did not have that PCR in that arm. So they did better as compared to the control arm. So a number of studies have investigated this impact of addition of IO agents to NACT on PCR rates in HER2 negative breast cancer. However, till date only Pembro has concluded in a phase 3 study which has shown a long-term benefit and has received a regulatory approval in this setting. Other agents still are in the investigational setting. So important highlights for two of the trials I'll mention. One is Keynote 522. Keynote 522 was basically including the T1C node positive or T2 to T4, any node positive TNBC who were good performance status. They were also evaluated for the PD-L1 expression, and they received the standard of care neoadjuvant chemotherapy, but along with carboplatin. So Pembro was given in the first phase of neoadjuvant with carbo and taxane, followed by the second phase of neoadjuvant with AC and Pembro. Then patient was forwarded to the surgery arm in case of a good response, and followed by that they received pembrolizumab in the adjuvant setting for remaining 9 cycles. And the control arm did not include pembrolizumab as inclusion, otherwise the arm was same regimen. And the primary endpoint was PCR, and secondary endpoints were PCR and EFS, of course. This slide shows actually that patients were, at par balanced in both of the subgroups, with majority of patients premenopausal, younger, as we see in the TNBC cohort. And this trial also concluded that the quantum of benefit in terms of PCR was more in patients who received pembrolizumab. And though the difference was a little more skewed in favor of the PD-L1 expressor, however, the PCR rate was increased even in the non-PD-L expressors also. So PD-L1 more than 10% versus, less than 10% did not affect the PCR achievement. However, the quantum was different. So this was 18 months PFS, which showed that Pembro group fairly did well. We have updated analysis of the result also, say after 37 months, which is still showing a benefit favored in terms of PFS in Pembro arm. So, this trial concluded that this is the updated result which I highlighted, and the absolute EFS benefit with addition of Pembro was more actually in the NACT arm. The node negative patients had superior outcomes compared with the node negative, compared with the node positive patients, and the magnitude of benefit of adding Pembro was similar in terms of distant recurrence-free survival, while there was also numerical, but it was not a statistically significant improvement in OS. Adverse event, we know, immune checkpoint inhibitors, there was nothing new add-on in this trial. And, but this trial actually left us with few of the important questions. Should Pembro be continued in the adjuvant setting in patients who actually achieved the PCR? Should adjuvant Pembro be administered concurrently with other adjuvant therapy regimens where they did not include a platinum or anthracycline? While will the addition of Pembro also improve outcomes if patients treated with a different NACT regimen? And if suppose somebody has already started, can we add on Pembro in the second or third cycle? Or if somebody has not received it in NACT, what is the quantum of benefit in the adjuvant setting? Similarly, IMPassion, the trial schema was more or less same. Atezolizumab add-on to the standard AC followed by taxane arm, followed by surgery and adjuvant. And the primary endpoint was PCR and the key secondary endpoint was EFS. This trial also again highlighted there was a quantum of difference with the addition of IO to the NACT arm, and the patient achieved more BCR when IO was added. And it was also irrespective of the PDL1 positive versus negative, though quantum of benefit was more in PDL1 positive. So similar conclusion. Another study to highlight is GPAR-NEO, which included durvalumab. However, the important point in this trial was patient did not receive adjuvant IO in this setting. So this study failed to show that PCR was better in terms of when patient achieved IO. And also one study to mention is NeoTrip PDL1 study, where atezo was used in the neoadjuvant setting. This study also failed to show that there was increased PCR rate when IO was added. However, they concluded that it was not the primary endpoint. Primary endpoint was to see the EFS, which is still awaited. The data is still immature. So, if I conclude, so the status of IO is, I mean, not very much clear in terms of the long-term outcomes. Though if we take PCR as a surrogate marker of the, say, DFS and the OS in the long term, adding IO and for that matter carboplatin did make a difference. So my take would be to add on IO in a NACT regimen in TNBC high-risk patients, where we see that it can make a difference in achieving a PCR and then leading on to advantage in DFS.